like to introduce Tammy Dolphins of the UNMC's Children's Hospital Medical Center, who works in the cardiovascular clinic in the management of dyslipidemias and hypertension in children. So we're grateful for her expertise and experience. And with that, Tammy, I'm going to have you go ahead and get started. Thank you.
Okay, thank you. Hopefully you can all hear me just fine, and I'll do my best to get through this as quickly as possible to make up for lost time. First, I'd just like to start out, do I have control here to review the objectives for today? We're just going to briefly discuss the epidemiology of pediatric obesity. All of you who have logged in today are aware of the epidemic of pediatric obesity, so we won't spend a lot of time reviewing statistics that you all already know. Review the lipid disorders that we see in childhood and what is related to pediatric obesity. Understand the definition of pediatric hypertension, and then also discussing diagnosing, treating, and management of these cardiovascular comorbidities. I work in the Preventive Cardiology Clinic, as many of you may already know. The way that this works in our cardiology department is that we receive many referrals from primary care providers with patients who have unmanageable cholesterol profiles, hypertension, and/or obesity. These patients are becoming greater in number. I believe many of the patients that we see here are ones in which the primary care provider has concerns on what type of medication to use and when to start that medication. The way that we work is with Dr. Scott Fletcher and myself. We have an RN, and then we also have a dietitian who sees these patients in the clinic. We use a typical protocol follow-up that we've designed on our own based off much of the literature, and then really just encourage patient and family to use conservative measures, as many of you are likely doing. This is just a schematic of our basic protocol that we would use for a borderline fasting lipid profile, but the only thing I want to point out on this kind of busy slide is right up here that we repeat the test. It is almost always that we will repeat a fasting lipid profile a second time before we jump to any other conclusions for how to treat or manage this patient. So the motivations behind having a high-risk preventive cardiology clinic, as you all know, is behaviors, habits, and risk factors begin in childhood. Many of these are related to weight and obesity, and this is reversible, especially if you start early. This is a diagram that I especially like because it spans such a long time period. You've all probably seen these numbers before. Basically, the prediction of pediatric obesity and its current prevalence. You can see the high estimate will become 5 times that what it was a generation ago, and even the low estimate will still become approximately 3 times what the numbers of pediatric obesity were before. And we can switch. There you go. And then you've probably all seen this diagram also, just showing the various age groups of pediatric obesity spanning a 24-year period, which is almost all of which are more than doubled, even some here in the school age to be tripled as far as the percentage of childhood overweight prevalence. So what cardiovascular risk factors do we have when we're talking about kids with pediatric obesity? Of course, we have hyperlipidemia or dyslipidemia, those with hypertension. Then we throw in some of these other cardiovascular risk factors of smoking, physical inactivity, the obesity, which is what we're talking about today, type 2 diabetes, echocardiograms that suggest an increased ventricular mass, which is also a known risk factor. And then the genetics, just having that genetic workup or the relatives with the significant risk for coronary artery disease. So when we discuss metabolic syndrome in the adult population, it includes 3 or more of the following: obesity, triglycerides, cholesterol levels, and blood pressure. In the pediatric population, you have to add the percentiles by age in there. So it becomes a BMI greater than the 97th percentile, triglycerides, which are elevated, low HDL, elevated blood pressure, and then of course impaired glucose tolerance. And having just 3 or more of those is consistent with the metabolic syndrome even in the pediatric population. If we look at this in the opposite way, as far as the prevalence of metabolic syndrome based on the degree of obesity in these children, approximately 50% of severely obese people, now excuse me, this is not just children in this study, but approximately 50% of severely obese, that is a mean BMI of 40.6, have metabolic syndrome, and approximately 40% of those which fall into the moderate obesity category. So it just reminds you to keep in mind that if they do have this level of obesity, you need to look for all of these risk factors here and test for them and get the proper treatment started. So studies that link childhood risk factors to adult cardiovascular risk factors. There are numerous studies out there, and I couldn't list all of them, but just to point out a few that I like, we know that obesity is somehow linked to hypertension. There's a couple of journal articles which both state to the same statistic of 3 times the high risk for hypertension than non-obese children, both published in the recent past. Also, that we know that atherosclerosis begins early in childhood. This is very evident from the Bogalusa heart study, in which the healthy young soldiers had autopsies performed to show this atherosclerosis already present in the late teens and early 20s. Coronary artery calcification in young adults. We know that there's a definite link, and this can be predicted based on childhood numbers of increased blood pressure, increased BMI, and low HDL. This study published in JACC shows that there's a direct correlation with the amount of coronary artery calcification noted in the young adult population. And then finally, carotid intimal medial thickness, which is not something we typically use yet in our preventive cardiology clinic, but we hope to do in the future with the ultrasound imaging of the carotids. But adult cardiologists are commonly using this study, and it was found that in boys and children that total cholesterol, LDL, HDL, and blood pressure were excellent predictors of what the carotid intimal medial thickness would be, and in girls it was interesting, it was different numbers. Total cholesterol, triglycerides, and BMI were predictive of that. So when we take all those studies into account, we need to know, well, do these kids grow out of it? Are these kids who are obese at a young age still just eventually going to grow out of it, and we don't need to worry about their cardiovascular risk factors? Having a BMI greater than the 85th percentile at any one time between the ages of 2 and 4.5 showed that 5 times more likely to continue to be overweight at age 12. And again, these statistics that you're all familiar with, 60% of preschoolers are going to remain overweight at age 12, 80% of elementary school kids at age 12. So prevention starts early, and that's where I think that this Foster Healthy Weight and Youth is really a great program, and learning about, or excuse me, identifying risk factors for obesity is going to really make a difference. So coronary risk factors that increase throughout childhood. This is an excellent study that I know Dr. Fletcher and I refer to frequently, called the School Project Study, that was published in 2006 from Wausau, Wisconsin, where 715 students were evaluated in the various grades for coronary risk factors. That assessment included the fasting lipid profile, and then other coronary risk factors was kind of its own separate category. The abnormal fasting lipid profile, of those 715 students, 18% of them had an elevated cholesterol, 27% had abnormal LDLs, 10% had low HDLs, about the same 9% had elevated triglycerides, and then just 5% had a pattern B LDL phenotype, which I will discuss later on in this presentation, but that is important when thinking of long-term coronary risk factors. Of the non-lipid coronary risk factors, 28% of the students were hypertensive, 16% overweight, which correlates with general population, 10% used tobacco, and then just 0.2% actually had an impaired fasting glucose, which was pretty surprising to these researchers. I think they thought they were going to find a significant difference, or excuse me, significant abnormalities in the glucose numbers. I really like this diagram because this shows that there's definitely some environmental factors that play a part here, and also that prevention needs to begin early, and that is, you can see in the second graders, only about 10% of them had 2 or more coronary risk factors. But by the time they were in 11th grade, nearly 40%, so about 4 times as many children had 2 or more of those coronary risk factors that were discussed earlier. So before we talk about assessing for those coronary risk factors and when we test for them and how we treat them, just to review some basic science, and we'll go quickly through this to catch up on some time. The cholesterol molecule is a complex macromolecule. It has the sterile component, fatty acids, and protein. We know these are water insoluble because they transport proteins in the plasma. Cholesterol itself is an essential component of cell membranes, hormone production, and digestion, which is why we can't cut it out completely. Cholesterol is then divided into classes: HDL, LDL, VLDL, and then your chylomicrons. Typically, chylomicrons really should only be present in the non-fasting state, which we'll talk about that later too. So they're divided on these classes based on their size and their density. Your HDL, which is the smallest and most dense, makes up about 1/4 of your total cholesterol. This is the good cholesterol. It takes part in reverse cholesterol transport, goes into the tissues, removes that cholesterol, takes it to the liver for excretion there. When I talk with families all the time, they always get HDL and LDL mixed up, and so I describe HDL as the happy cholesterol because H is for happy, and so encourage them to have as much happy cholesterol as possible, so then they never forget. LDL cholesterol makes up the majority of your total cholesterol, about 50% or more, and its job is the opposite of HDL, to take that cholesterol from the liver and into the tissues. There are receptor sites located in the liver for those LDL, which becomes important when it comes time for treatment of LDL abnormalities. And then triglycerides are, of course, your main storage of fatty acids, your VLDL and chylomicrons, which are the actual largest of the two. Typically, we should not see, like I stated earlier, the chylomicrons unless you're non-fasting. And this is just a schematic to show you the density and the size of these varying molecules. Your HDL components down here, LDL, and then VLDL. So now we reviewed our basic science. So what does this really mean? This is where we discuss cholesterol screening in pediatrics. Very interestingly is that the American Academy of Pediatrics recently updated their guidelines in 2008 as far as what the recommendations are for screening. And I'd say just in the last year or two, we've really noticed, probably just the last year, the impact in our preventive cardiology clinic, because a lot of this screening is being done based on these new guidelines. Any child who has a positive family history, that includes a parent or a grandparent with a dyslipidemia or a history of premature coronary artery disease, that's heart attack or stroke or stent placement or myocardial infarction at an age younger than 55. And if there's a parent with a cholesterol greater than 240. Most of the parents that I see in clinic have no clue what their cholesterol is, and after their child's been seen in the clinic, the parent then feels somewhat motivated to go and get their cholesterol checked. But anyone who has that history should have a screening. If the parental history is unknown, even if just one side of the parental history is unknown or the child is adopted, a screening should be performed. And other cardiovascular risk factors, as we discussed earlier, being overweight or obese, that's BMI greater than the 85th percentile. If we look at that 85th percentile, that encompasses a very large number of patients who need to have their cholesterol screened, because there's a significant number that fall into that category. Hypertension, if their blood pressure falls above the 95th percentile, then it's important to have a cholesterol screening. If they report a history of cigarette use or tobacco use and a history of diabetes. It's important to screen these after age 2, but no later than age 10. Screening before age 2 is not recommended because the overall total cholesterol and LDL lipoprotein numbers really aren't established until after age 2. And that excess fat is really important for kids at that age, so we wouldn't want to put them on a low-fat diet then. Screening in the context of a well child visit. I really like this, and I'm starting to see more patients here that have had a screening done. You know, parents weren't even really sure why it was done, but it was just done as part of their overall school physical. If you're going to take blood for other reasons, you might as well just lump it all together. So that really helps us to not miss any of these patients. So what screening blood tests are available? There's a number of things available. I know finger stick method is often available as a back office lab run and is quick and inexpensive and easy to do. It can give you just a general idea of what that total cholesterol number is going to be. If that is then abnormal, you know, then proceed on to the fasting lipid profile to give us a better idea. Fasting lipid profile, and I apologize, this equation here is not the Friedewald formula that you're typically used to seeing. This is based, this shows your triglycerides that need to be divided by 5. Patients who have very elevated triglycerides do not have accurate measures with their fasting lipid profile. This is the recommended approach, having the fasting lipid profile, if you are going to refer this patient on for a preventive cardiology evaluation, because it really helps us to break down what these numbers are. Please don't send patients who have just a finger stick back office measurement. NMR lipo profile, if some of you may be familiar with this study, this is a study that we frequently use in our clinic. It's really not all that expensive anymore. It used to be very expensive, but what it does is break down the lipoprotein phenotype, and we're going to discuss furthermore that pattern B LDL phenotype that I briefly mentioned earlier. What this does is kind of stratifies the risk of these patients and helps you make decisions as to if you need to be aggressive in their treatment or not. But it's an excellent test, and it really opens your eyes to what lipid abnormalities could be out there. And this is a study, and it looks like it didn't come through. These were highlighted here, so you can't see the numbers. The LDL here was actually 89, if I recall. It was less than 100, and HDL 27, elevated triglycerides. So overall, this fasting lipid profile doesn't look all that bad. However, when you break down the particle number, and I'm trying to remember these numbers exactly, but the actual number of LDL particles was 1,600 and something, which falls into this high category. And then of those, the ones that are small LDL particles, or the ones that are actually going to cause the atherogenic damage, were very high, greater than 1,200. So they made up the majority of those LDL. So in this patient, we knew we needed to be quite a bit more aggressive than just recommending a little diet and exercise here. It puts you at very high risk to have these elevated cholesterol numbers, or excuse me, the elevated particle numbers. This is the reference range that we typically use in our clinic. So lipid disorders in childhood. Lipid disorders in childhood are really somewhat difficult to diagnose because they're really not all that symptomatic unless you have a high level of suspicion based on those cardiovascular risk factors that we've already discussed. The only two that are potentially symptomatic include your familial homozygous hypercholesterolemia and then also hypertriglyceridemia. The other ones that fall into the asymptomatic category include the heterozygotes for FH and then familial combined hypercholesterolemia, which you may not hear much about, and then dyslipoproteinemia, which is diagnosed from that NMR lipo profile. In familial hypercholesterolemia, there's an LDL receptor defect on the level at the level of the liver. These patients are unable to clear LDL from their plasma. This is an autosomal dominant trait. For the heterozygotes, it's approximately 1 in 500, and homozygotes is 1 in a million. It's an abnormality of chromosome 19. The most important numbers probably to learn here as far as familial hypercholesterolemia is that in a study that was published, males who had heterozygous FH documented from genetic testing, 50% of them had at least one type of coronary ischemic event by age 50, and 85% of that population had a coronary event by age 65. These patients are at significant risk at a very young age, and we know that this occurs very early. To break down the two types of familial hypercholesterolemia, Heterozygotes are typically going to have a total cholesterol between 350 and 550. I think it's getting a little bit on the high side for heterozygotes, but in that range. Homozygotes as high as 1200 for total cholesterol. The typical LDL reading is approximately 240 in these patients. In this case, one of the two alleles of the liver is damaged, but there's still 50% of normal LDL receptor activity. These patients, heterozygotes, will be responsive to statin therapy. Homozygotes, as I stated, are very, very high total cholesterol, also very high LDL. Both of the alleles are damaged. There is no receptor activity at the liver. Therefore, these patients are completely resistant to pharmacologic treatment. Statin therapy has no effect. The only answers here is to undergo weekly plasma apheresis or liver transplant. Clinical findings of FH, like I stated earlier, there's not a whole lot, but you may encounter tendon xanthomas, which is present in 70% of cases by age 30, may be present in childhood in the pediatric population. If you have a homozygous FH, which is rare, 1 in a million, 100% of those patients will have tendon xanthomas present. Corneal arcus, this is the findings in the cornea, and I've got an example here for you. Typically, it's pretty sensitive for diagnosis at ages less than 35. African Americans don't really have a real sensitivity for this. Symptoms really are sudden death or myocardial infarction, especially when we're talking about the homozygous. Typically, these patients will die before age 20. Here's tendon xanthomas present at the patellar tendons, Achilles tendons only. And then the corneal arcus. You can see along the edges here the deposits of cholesterol, and then oftentimes you'll get this kind of shaded area there. That's what corneal arcus. We don't see much of this, but we do look at the eyes during a preventive cardiology clinic. When diagnosing FH, there is genetic testing available, but it's not typically performed, and that's because you can oftentimes make this diagnosis strictly from the numbers that you're seeing. This was an interesting table that I found. It is said to have 98% specificity for these patients, but if you have just a general population patient that's age less than 18, that has a first-degree relative with FH, if they have a total cholesterol of 220, more than likely they will have the diagnosis of FH. If they're in the general population with no relatives, greater than 270 can give them a likelihood of having that diagnosis. Hypertriglyceridemia, this is the second potentially symptomatic disorder. This is something that you will see in the pediatric obesity population because it is directly related to features of the metabolic syndrome. Basically what's happening is your VLDL particles are overproduced. If you were to get an NMR lipo profile, there would maybe be a pattern B lipoprotein profile. Triglycerides can be greater than 300, even as high as 1,000. Initial management of hypertriglyceridemia is weight control, exercise, and avoidance of sugar. That's pop, Kool-Aid, juices. When we start to cut those out in these patients, the triglycerides drop dramatically. We also get excellent results with our pharmacologic therapy, which we'll talk about here in a minute. Triglycerides greater than 1,000, this would likely be an abnormality of a lipoprotein lipase deficiency. It's an autosomal recessive disorder where you have that hyperchylomicronemia, where those should really only be present if you're non-fasting. So if you're fasting and you're there, that's a definite triglyceride abnormality. These patients are at risk for acute pancreatitis. If you have a pediatric patient who presents with recurrent abdominal pain and you've done every lab test that you can think of, make sure that you've checked a fasting lipid profile. These patients are going to have eruptive xanthomas, which are different than the tendon xanthomas. These will rapidly recede with triglyceride lowering. So they may be present for a day or so and then go away the next day, but this is what these look like. So the asymptomatic disorders, heterozygous hypercholesterolemia, we've already discussed familial combined. I'm going to go through quickly, and then dyslipoproteinemia. The reason I'm going to go through familial combined hyperlipidemia is because it's much more prevalent in the adult population. That's because there's not really a clinical presentation in children. Although in children that have obesity and other coronary risk factors, I'm going to point down here, associated with metabolic syndrome and insulin resistance, they're going to present with very high triglycerides and low HDL. It's actually a very common finding in the adult population and very high cholesterol numbers here. And this is just a comparison just to visualize the two. They may or may not present with childhood hypercholesterolemia and will not have tendon xanthomas, but they do have your high triglycerides, low HDL. Here's your combined. Hypertension, diabetes, obesity, this is where you have the association with metabolic syndrome that we may be seeing in these pediatric patients. Respond favorably to diet and weight loss in the combined hyperlipidemia, but not the familial hypercholesterolemia. That determines the two. So dyslipoproteinemia, and again I apologize, I'm trying to hurry so I can get through most of these slides, but this is a very important diagnosis because of the risk that you can have with a pattern B LDL. This is a study of what the NMR lipoprofile does for you, is to break down the size of the LDL particles and the particle number. If you have predominantly small and dense LDL particles, now not HDL particles, which are the good ones, you're at very high risk for coronary artery events. In the endothelial cells that line the arteries, these allow oxygen and nutrients to pass through. Those holes measure approximately 26 nanometers in diameter. So when your LDL particles range in the 20 to 30 range, the ones that are smaller than 26 nanometers are going to pass into that arterial wall and become the atherogenic ones, where the larger ones are going to continue to pass by and not become atherogenic. If you have an overall 5% smaller average diameter, this is going to be an increased 50% increase in uptake by the arterial wall. And then to show you that visualization one more time, here's your LDL particles, which range 20 to 30 nanometers. The ones that are small here are going to become atherogenic. So that's your pattern B LDL. Oftentimes these patients will in addition have an elevated triglycerides and a low HDL. This is also associated with metabolic syndrome. You can change your LDL phenotype, but it is very difficult. It takes a very significant diet and lifestyle modification for that. There's a striking increase in coronary heart disease risk. And just briefly, Lp(a), you've maybe heard this discussed more so in adult medicine. This is not something we check in the preventive cardiology clinic. And I'm just going to skip over in the essence of time. So to treat or not to treat, if you have a patient whose total cholesterol falls within the normal range, it's okay to retest in 3 to 5 years. If it's abnormal, weight management through diet and exercise, that is if they're obese and or have high triglycerides and or have those low HDL. Try the weight management, give them the conservative lifestyle measures first before jumping to the pharmacologic intervention. This includes a patient that would be 8 years of age or older and has an LDL that falls into one of these ranges. Again, greater than 190 is acceptable in a patient without other risk factors. Greater than 160 if they have 2 additional risk factors, and then LDL goal very low if they have type 2 diabetes. So the current medical management that's available, here's your bile acid binding resins, niacin, fibrates, fish oils, cholesterol absorption inhibitor. This includes Zetia or ezetimibe, and then statin medications. The AAP and the NCEP suggest that bile acid binding resins are really the only preferred and safe drug for children, and for the longest time this was the only drug that they would allow for children to use. It's somewhat effective in lowering LDL, an average of 10 to 20% decrease, but if you look at the numbers we might be dealing with in these population, 10% is really not going to get you very far. And it may in fact increase triglycerides, and in our high-fat, high-sugar society, many of these patients are going to have problems with triglycerides in addition to LDL. The way these work is to bind cholesterol and prevent reuptake into the circulation of bile acids. It's not systemically absorbed, which is why they say it's okay for kids. It's a high dose. It's given twice a day. It's a chalky powder that you mix in with liquids, and it tastes bad, and it makes kids feel bad, and compliance is horribly bad. We don't even start with this medication. We actually just skip right over the cholestyramine because we know we're not going to see good results with it. It doesn't mean that it's not a trial that you could try in the primary care setting, but your success rate is going to be fairly low. Niacin, this is not a medication that we typically use to treat pediatrics. There is a recommended dose, 25 to 75 milligrams per kilograms per day. This can be effective for treating low HDL and high triglycerides, but really the best treatment for low HDL and high triglycerides is going to be diet and exercise. Pre-treatment with aspirin is recommended, which raises even more red flags for treating children, which is why we also avoid niacin, in addition to the adverse effects associated. Fibrates, we frequently use fibrates in treating elevated triglycerides. Even though there is no dosage safety or efficacy established for children, it's very effective in treating hypertriglyceridemia. We don't get the adverse effects, at least not with our patients that have been using this for quite some time. It is something that we treat, after a trial of diet and lifestyle modifications has failed. The way fibrates work is to inhibit synthesis of increased clearance of VLDL, and then eventually that leads to a decrease in your VLDL production, further lowering your triglycerides. So we will occasionally use these in older children. Fenofibrate 48 milligrams is a really good starting point. I like to have a baseline creatinine and lab work before starting this medication. Compliance remains poor with almost all of these medications. Fish oils. This is an area that we are almost always recommending if parents ask about fish oil treatment. We do know studies show that this is effective for treating hypertriglyceridemia. The recommended pediatric dose of fish oil is 1 gram per day. Adult dose is 3 to 5 grams per day. I'll taper this up based on the patient's size, whether or not they're adult size. It is safe for patients who have to take daily aspirin or warfarin to take this fish oil, but should be discontinued if there's an acute bleed. Compliance is somewhat poor, but not as bad as some of the other medications. They are coming up with several products that are flavored fish oils, liquid fish oils. There's a lot of availability out there for fish oil options. Zetia is a medication that we use very frequently in the preventive cardiology clinic. This is your selective cholesterol absorption inhibitor. It actually blocks the intestinal absorption of cholesterol rather than acting at the liver level like a statin medication. We've seen very moderate reductions in LDL. The literature shows about 20% decrease, also an occasional decrease in triglycerides, and then of course the combination therapy that we frequently see in adult populations have a significant impact. These are the adverse reactions listed on the package. We haven't had any of our complainants complaining of this. It's a once daily dose of a very small 10 milligram pill. We actually do see good compliance with this because of this reason, and it could maybe be considered as monotherapy for pediatrics. We did a little bit of our own data collection here and followed about, 13 patients over the course of almost 2 years and showed actually very, very significant reductions in the LDL. Just point out here at the initial follow-up, the average mean of 6-month follow-up, we had 32% reduction in LDL cholesterol. And again, 23% at the final follow-up. But these starred are the significant results that we found. Statin medications are effective in lowering LDL. We all know that, and the cardiology world of adult medicine knows that. Many people are taking statins. Several studies out there to show decreased carotid intimal media thickening. The way that this works is to inhibit rate-limiting enzymes at the level of the liver. It lowers your intracellular cholesterol level and upregulates LDL receptors in the liver. Currently now, a few years ago, statin medications were not at all approved in the pediatric population. The first one to be approved was Prevestatin, which was Prevacol, approved down to age 8. regardless of pubertal status and regardless of a diagnosis of heterozygous familial hypercholesterolemia. Rosuvastatin, atorvastatin, and simvastatin are approved to age 10 now, and although the literature states post-pubertal and only for heterozygous FH. We do use all these medications whether or not they have a diagnosis of FH based on the guidelines listed earlier as far as the LDL numbers and the associated coronary risk factors. The exciting news for statin medications is that many of these short-term studies are showing that they're very effective. Adverse events associated with statin use include hepatotoxicity. This does require baseline liver enzymes and then quarterly. Typically we'll check quarterly for at least 1 year. If there are no abnormalities over that 1 year period, then we will check every 6 months for liver enzymes. Rarely are there symptoms associated with that hepatotoxicity. Myopathies or muscle weaknesses is the very popular one with statin medications. Myalgias that present with CK levels that are greater than 10 times the upper limit of normal. In kids, checking CK levels are difficult because of all their bumps and bruises and active activities. They may have slightly elevated CK levels anyways, so we want to make sure that number is 10 times the upper limit of normal before we jump to conclusions and decide to stop that statin medication. Of course, teratogenicity, which is very, very important to keep in mind with the teenage female population that may, in fact, be at risk for teenage pregnancy. It is still recommended to avoid these in prepubertal children, although the current research, just not long-term yet, is not showing any effect on growth hormones. So the strong association of coronary heart disease and dyslipoproteinemia is always very popular and in the limelight, but we tend to forget about the other non-lipid risk factors: smoking, hypertension, obesity, and diabetes. So going back to the school project, here's our our student population where 28% of these patients were hypertensive. That is having a blood pressure greater than the 90th or 95th percentile. Hypertension in kids is a little bit more difficult to define because we don't have the one number, 140/90, like we do in the adult population. We have to get out our graph, which I have hanging behind my door because I refer to it so frequently, of the FHWY's blood pressure tables, which I believe are very easily and readily available to you to show you what percentiles we fall into. Blood pressures ranging from 90 to 95% fall into the pre-hypertensive stage, 95 to 99th, and then of greater than 99th are as listed there. It's important to keep in mind that the FHWY blood pressure tables are for manual recordings and not your automated blood pressure cuff like many clinics use. There are tables available for the automated blood pressure cuff based on your brand name, and so it's important to make sure you're looking at the correct table. When in doubt, just get a manual blood pressure recording, because typically I know the Dynamap that we use does a calculation based on the mean blood pressure, which does not give you an accurate reading. And if you're deciding to make the diagnosis of hypertension and start a patient on medication, you want to make sure that you have an accurate number. This is considered abnormal if you've had 3 separate recordings. So keep them coming back every couple of weeks. You can recruit school nurses and things to help you check those blood pressures. The Muscatine study is a fantastic study because of the longitudinal cohort that they watched. This large number, almost 2,500 children, evaluated ages 7 to 18 and then reevaluated again ages 23 to 28. Of this large cohort of children, those that had a systolic blood pressure greater than the 90th percentile were 4 times more likely to be hypertensive. And same with diastolic blood pressure, 2 times more likely. These are your causes of hypertension in children. Less than 11 years of age, the most common is renal disease or coarctation of the aorta. Less common are some of the other renal issues, neuroendocrine issues, respiratory, sleep apnea, associated hypertension. And then the causes for greater than 11 years of age, renal disease and primary hypertension. I like to go back to this slide because in light of all of the pediatric obesity, we're running into more young patients, 7, 8, 9 years of age, that have sleep apnea. Maybe their hypertension could be related to that. And maybe even though they're 7 or 8 years of age, their body mass index or their weight is off the charts, and we might be dealing with just a strict primary hypertension. So this data, 1996, I think is maybe a little bit old to really have a cutoff point of whether or not it could or could not be primary hypertension. I found this diagram, which I really liked, showing, and I'll point out just briefly, primary hypertension here. You can see as young as toddler age and school-age children here, primary hypertension is a very large component of determining the cause for hypertension. Congenital such as coarctation and renovascular is only very high in this area. So your diagnostic evaluation, the first question to ask yourself is, could this be real hypertension? The reason I ask that is whether or not this could be real hypertension is many times you either have a false reading because of the wrong size cuff, or maybe the patient's extremely nervous and you really need to assess the whole situation before you determine whether or not this patient has, quote, real hypertension. So the first thing is to think about how old is the patient. Refer back to that chart that I just showed you to see now what is the percent likelihood of what could be causing this elevated blood pressure. Evaluate your overall clinical findings. Is there an arm-leg gradient? Is there a heart murmur present? Is there an abdominal mass present? And what does the history suggest? Many times when I'm evaluating a patient for initial hypertension, overall a basic history gives you the answer. If you can find out what's going on in their family history. Does every single relative on dad's side of the family take blood pressure medication? What is their dietary and nutrition history? Many times a patient comes to my clinic and no one has ever even asked them what their nutrition intake is, and many of these young teenage patients are drinking, several ounces, 3, 4, 5 Mountain Dews a day. They're having an excessive amount of salt or processed food because they're on the go and they're busy and they're grabbing things from a box or a can or the freezer, and it's quick and easy to make, but it's loads and loads of sodium, and they've never really even paid attention to that. Most of the teenagers drink very little water, 1 to 2 glasses a day at most. Most of their fluid intake is the previous beverages of pop and juice. Energy drinks is really a big one too. If they're having very high doses of caffeine, that could be contributing to this blood pressure. And then of course, what is their social history? So what studies are available to you when evaluating hypertension? I list 24-hour ambulatory blood pressure at the top of my screen on purpose. This is an incredible test. It gives us all sorts of great information, and it can help lead us down the road if we need to do further testing, more of this expensive and more traumatic testing for young kids. White coat hypertension is extremely prevalent in the pediatric population. This recent study showed that 47% of patients that had a mean age of 13, that had an office blood pressure greater than the 95th percentile, actually showed evidence of white coat hypertension and not true hypertension. If that is the case, it would eliminate the need for several other studies like echocardiography, renal ultrasound, lab work, and sometimes brain MRI and 24-hour urine studies. There's just so much that can be done to evaluate blood pressure. That's why I always recommend 24-hour cuff if that's available. We have 4 of those available in our clinic. Having a home or school blood pressure assessment, this is helpful, but you want to make sure that the family is taking blood pressures correctly and using the right size cuff. Same within your clinic, same with the school nurse. I have had some very cooperative school nurses take blood pressures 3 times a week sometimes and fax them to me monthly to evaluate these patients' blood pressure. Your laboratory evaluation consists of these listed here. Number 1, urinalysis, microalbumin, a study of the urinalysis. This is very important to rule out any of those underlying nephrologic conditions that could be causing the elevated blood pressure. And then your imaging studies to include echocardiogram and renal ultrasound and Doppler studies. Echocardiogram is, of course, to rule out coarctation in the younger patients, but also I use this tool to evaluate for left ventricular mass and function. This is an excellent study to determine whether or not treatment is necessary for these patients. If we're starting to see left ventricular hypertrophy or depressed function, then we know we have some early end-stage organ damage with that. So hypertension treatment, and we're just going to wrap up real quick. I'll go quick these last few slides. Nutrition and exercise. Encourage these patients to meet with a dietitian and to educate them on the DASH diet. That is the diet against systolic hypertension. Effective sodium restriction is very difficult in these patients. That's because the family is usually on the go and they need quick and easy food. And if you start looking at labels of the common preschool and school-age lunches, macaroni and cheese, Chef Boyardee, all those sorts of things, they are just packed full with sodium, and it's difficult to avoid. Exercise contract prescription, going back to sodium, one of the comments I make to my families is just to pay attention to the sodium. Don't so much try to restrict it, but just try to avoid foods that have greater than 25% of your daily sodium intake per serving. And many of them are shocked at that, and that seems to be an effective use of them trying to avoid their sodium intake. Increase exercise using a contract or a prescription, having the patient write down or record things in a diary and bring them back to you makes them accountable. Here's your DASH diet. Diet nutrition counseling, I always think that this is interesting that 34% of calories come from fat in the average diet of a school-aged child, and school lunches are up to as high as 40% calories from fat. Keeping a 3-day food diary is really good for these kids. You can get dietary counseling as an outpatient if you wanted to just refer them to a dietitian. Fiber supplementation when discussing treatment of elevated triglycerides or cholesterol. Child's age plus 5 grams per day up to a maximum of 20 grams per day. Make sure the kids are drinking fluids to go along with that fiber. Overall, targeting lifelong habits, making long-term changes rather than diets and small changes. Regular aerobic exercise, we know improves HDL and lowers triglycerides. Competitive sports are not the answer. This was the last point I wanted to make as far as exercise. Kids tell me, well, I have weightlifting every day in the summer, so I'm getting my exercise. Well, that's not the same as the aerobic cardiovascular exercise that they need for a minimum of 30 minutes to lower their cholesterol, improve blood pressure, and increase the HDL. And this study just pinpoints the difference that diet versus diet plus exercise training can have on the lab numbers. Triglycerides significantly improved, insulin significantly improved. Oh, and finally, I'm sorry, I know we're running long, but systolic blood pressure and diastolic blood pressure, if it is consistently greater than the 95th percentile in your 24-hour blood pressure monitor, suggests true hypertension and not white coat hypertension. There's really not a single recommended drug regime for children. It depends on the patient, just like it does in the adult population. Diuretics are very effective in the African American population because it's very common low renin volume dependent hypertension. ACE inhibitors I frequently use in the teenage boy population, mostly because you can take a once daily dose of lisinopril or enalapril and start low and have room to increase. Once daily is the key to get these kids to stick to this regime. Teenage girls, I tend to avoid ACE inhibitors, and that's because they're contraindicated in pregnancy. And I guess I shouldn't specify just teenage girls, but young girls also. Calcium channel blockers tend to be fairly effective in treating them. Beta blockers, not really the most effective medication in treating blood pressure. Most of the research that has come out in the last year or so has said to avoid beta blockers as a primary treatment for elevated blood pressure. And we rarely use ARBs. So overall, all of you know the answer to this, that why preventive cardiology clinics won't solve this problem, and that's because we have primary care issues, we have public health issues, school and family issues. There's so many components to treating these kids' cardiovascular risk factors that one area, if you get it under control here, it may not be under control here with the family. If public health can make some changes, maybe the school isn't doing enough. And so it's just an overall battle that needs to be taken on from multiple standpoints. And then just keeping that family involved. Just want to point out right here, ongoing education for patient and family members. And that's all. Thank you.
Thank you, Tammy. That was excellent. Definitely worth the wait. Apologize again for the technological difficulties. I don't know. I can't see the questions, but I don't know if, Tammy, you can see the questions. If there are any registrants who have questions, please type them in now so that she can start answering those.
I don't see any yet.
Okay. I have a question. This is Dr. Lester. How long, I know you talked about the effectiveness of different strategies, but do you give a trial for a certain amount of period before you go to meds, or say for, does it depend on the type of dyslipidemia they have? So do you give like a kid with low HDL and hypertriglyceridemia some time on like maybe weight management, increasing exercise before you would go to medication versus starting somebody with elevated LDLs more quickly on something?
Sure. Sure, good question. Really, medication is really my last measure of treatment for these patients, and you really have to treat the patient themselves. You give a good example of low HDL and high triglycerides, and we know that that is very responsive to diet and exercise modification. So someone in that area, I would maybe wait quite a bit longer before starting them on a fenofibrate, for example. I like to give them at least 3, if not 6 months, sometimes even longer than that. If they've shown progress, and by progress I mean progress to me in the preventive cardiology clinic is growing taller without gaining any weight, or maybe gaining less pounds than you did in the last 3 months, and really changing that trajectory of weight gain. And if I see an increase in HDL cholesterol, I always let them know that, you know, this, you can't hide this. You can't change your HDL with medication or food. This is directly aerobic exercise. And so I know that you've been working hard. I'm going to give you another 3 or 6 months or whatever to see how much further you can get. I think that most of these kids really need to see that small progress because they all feel fine. They don't feel bad at all. And so if they can see the numbers, I always can, you know, encourage, we kind of make deals, you know, okay, 3 more months, let's see where you're doing in 3 months, you know. And so I don't really have a cut point unless I know that they're not trying to make a change. The HDL has not changed. They've continued to gain weight in the same, you know, trajectory as before. If I can tell they're not motivated to make the change, then it's time to start medications. And then as for LDL cholesterol, it's based on the cut points listed in there, that 190, 160, 130, and the additional cardiovascular risk factors. That too, I will also give them at least 3 to 6 months to make, you know, lifestyle modifications to see how far we can get before medication. So, good question.
Okay, great. Okay. I also had a question on the range of age of when to start screening. The age, not before age 2, but definitely prior to age 10. Do you then add in, like, if they have other risk factors, like, okay, yeah, they're overweight or obese, but do you have like a family history and things like that that you would start screening like by age 2 or 3? Or this is a common question I get when I talk to physicians.
Yeah, definitely not before age 2 because you're not going to get an accurate measure and you're not going to change a lot. But we see 3- and 4-year-olds that have had fasting lipid profiles. So if they have any of those risk factors, even one family member with an elevated cholesterol, or if you have a 3-year-old with that's obese, you know, then it is perfectly fine to check a fasting lipid profile. That's the time to do the screening.
Okay, great. And I think we're still having a little bit of difficulty with the audio. So if you can email, if your registrants have questions, if you can email those questions. And it's Tamis, Tamis, @nebmed.org if you have any questions.
Or I think you can type into that chat area. I can see that.
Okay. Are you seeing a lot more referrals? You said you were over the last year because of the screening guidelines, but are a lot of the kids coming with obesity? Is there?
That's oftentimes an associated comorbidity, but I'd say that I see more, a lot of times I'll ask families, why was this done? Some of them know because, there's a family history of, a heart attack at a young age, but some say, well, it was just, time for their school physical, and so my doctor wanted to do this. So I'm seeing more of those patients where it's just being done because, they were there for a school physical. But yes, I'm thinking the reason their primary care provider ordered that test is because of the obesity or even overweight or hypertension or something like that.
Mm-hmm. And I think, too, keeping the conversation about the health consequences, those comorbidities, you have much more of a hook for families to become involved and to be motivated to make some changes, whereas if you're just talking about their weight, that sometimes does nothing to motivate them. But,
exactly.
Well, I guess if we don't have any more questions, we definitely appreciate your time. And tune in for the next Foster Healthy Weight and Youth webinar, which will be in September, and dealing with bariatric surgery. So go to visit cme.creighton.edu for the post-test, and you will receive a link per email in the next day. So thank you.
Thank you.
Thank you, Tammy.